daughters of DES was a medication given to prevent miscarriage. So here these poor women are getting this medication thinking it's going to help them. It actually caused all sorts of problems. So sorry for the confusion on that. Prescribed in the 40s to the 60s to prevent spontaneous abortion and premature labor. Female offspring have small uterus without the normal bulbous fundus and short cervix. Okay. And then, of course, agenesis is the congenital absence of a uterus, and also known as uterine aplasia. You could also have agenesis of the cervix. So here are these. So this arcuate has a smaller indentation than the bicornuate. This is that duplication. Septate has a dividing septum, however, the fundus is normal and unicornuate. All right, uterine masses. The most common by far is going to be fibroids, and the location just is the name of the fibroid is described by their location. So reminding you what the layers of the uterine of the uterus is. This outermost layer is the serosa. The innermost layer is the mucosa. So if you have a fibroid that is under the serosa but distorting the shape of the it looks like the myometrium is distorted, that's a subserosal. If you have one that's distorting the contour of the endometrium, that's submucosal. If you have one in the cavity that is on a stalk like this, that is pedunculated. I guess those are the, oh, and then if you have one that's completely contained within the myometrium, that's intramural. These submucosal ones are the ones that wreak havoc with your period, cause heavy periods. All right, uterine adenomyosis. We had already talked about this, that this is a type of endometrium that grows into the myometrium. It is benign. It does not bleed with the hormone cycle. It's a product of multiple pregnancies, and you could have elevated estrogen levels. It makes for a bulky uterus, especially on the posterior side. You can have heavy bleeding. You can have prolonged bleeding and irregular cyclic bleeding and painful bleeding, painful periods. It has a kind of a, the look of it on ultrasound, it has these vertical shadowing lines. Sometimes there's these little cystic pockets all within the myometrium. So sonographic findings: diffuse uterine enlargement, thickened posterior myometrium, small cysts, looks like Swiss cheese or honeycomb. They are non-vascular. Subendometrial cysts, myometrial heterogeneity with ill-defined endometrial borders. So what this means is that sometimes you can't, there's no distinction between the endometrium and the myometrium. You can't see where you can't see that stripe and the borders of it. It may mimic a fibroid because it can be focal, and MRI gives you a better characteristics. So multiple bright echogenic foci. This isn't a typical, but a typical look would be more like Um, it would look more um, like, see how this has those vertical shadowing lines? Like that's a bulky posterior. So that's kind of a typical look for it. Okay, endometriosis, external or indirect, functioning endometrial tissue present outside the uterus. So while adenomyosis does not fluctuate with hormonal changes, endometriosis that's outside of the myometrium does. So found anywhere in the pelvis, ovary, fallopian tubes, broad ligament, external surfaces, the uterus, peritoneum, cul-de-sac, bladder, bowel, cyclically bleeds and proliferates so it can grow and spread. It's similar in appearance to pelvic inflammatory disease and ectopic pregnancy. It is diffuse, meaning that it's kind of all over the place. Endometrial plantings within the peritoneum, rarely diagnosed by ultrasound. This is more symptom-based. So if somebody goes to the doctor and is complaining of different symptoms, pain with their periods and so forth, they pretty much, as far as I know, I think that this is pretty much how it's diagnosed more commonly. Localized endometrioma, which is a focal collection of those cells. It's smooth looking. They call it a chocolate cyst. Has anybody seen that? Like this? It's kind of a homogeneous, well circumscribed, low level echo lesion. Many times you'll see it on the ovary. Discrete mass, which can be in multiple sites. All right. Endometriosis can be asymptomatic. It can also cause severe dysmenorrhea, which is severe pain, chronic pelvic pain, premenstrual dyspareunia. Dyspareunia, everybody knows, is painful intercourse. Sacral backache during menses, infertility. Causes are peritoneal seeding. So retrograde flow, endometrial cells, I suppose those cells kind of proliferate and spread. Metaplastic transformation of peritoneal epithelium into endometrial tissue. Traumatic spread from surgeries or amnio. Traumatic, so from trauma, surgery or amniocentesis, I suppose. That's what that is. Sonographic findings, bilateral or unilateral ovarian cysts with anechoic to solid internal echoes, depending on the amount of blood, of blood and its organization. Chocolate cyst has uniform low level internal echoes like this. And they do not regress over subsequent cycles like a hemorrhagic cyst will. So everybody knows this is a hemorrhagic cyst. You can tell because it's got this thin little, looks like spider webs, this little webbing. And these will eventually reabsorb. The body will break down this blood, it'll reabsorb, and they will resolve within a few cycles. But endometriomas do not do that. Peripheral, punctate, or linear bright echogenic foci. I suppose it can look like that, peripheral, punctate, or linear bright echogenic foci. Endometriotic plaque on posterior surface of uterus, and occasional fluid level seen. Have you guys ever seen what's called fluid level? That's when you have two different densities of fluid. So here's a good example. This is what's called a fluid level. And does anybody know why it looks like this? Like, it looks like it's defying gravity. But does anybody know why it looks like that? Because on transvag ultrasound, this is actually posterior. So if you were to take this image and rotate it clockwise 90 degrees, that would actually be the actual orientation. So in a transvag ultrasound, this is the person's back of their body. So this, their behind would be here and their abdomen would be here. So this is settled just like, you know, normal with gravity. It's just that the orientation of the picture makes it look like that. And the reason that it separates like that is because they are two different densities. Okay. Here's another example. I didn't even have to look that up. Cystic ovarian mass with fluid blood levels. So one of these would have low, one of these is blood. I suppose this looks more solid and this looks like it's probably blood that's starting to coagulate. And this is that endometrial plaque on the posterior surface of the uterus. So treatment, ultrasound guided drainage, recombinant interleukin-2, I suppose that's a medication, chronic admin of gonadotropin releasing hormone to suppress response of endometrial tissue. So I guess you need to have, this is a gonadotropin that's released from the pituitary. So they must inject it and suppressing the estrogen so that it has a chance to heal. And results appear promising, which is good. Hormones to stop cycles. So you could take birth control pills, progesterone drugs. I believe that's to counter the estrogen, and these other things. Lysis of adhesions with laparoscopy. So you can go in and have it surgically removed, and pregnancy. Will pregnancy will cause it, they'll hold it. Okay. AV malformations, vascular plexus of arteries and veins without intervening capillary network. It is rare. It can be congenital versus teratogenic, which means it was acquired, I believe, usually by some sort of trauma, perhaps by medical intervention, right, surgery. So pelvic trauma, surgery, or gestational trophoblastic neoplasia. So this gestational trophoblastic neoplasia is molar pregnancy. Can cause this AV malformation. Sonographic findings will be subtle myometrial in homogenic tubular spaces within the myometrium, intramural uterine mass, endometrial or cervical mass, prominent parametrial vessels. Color Doppler shows flow within the structure. So these are vascular structures, obviously, but they do show flow versus something like a hemangioma, which would not. Whoops, sorry. And spectral high Doppler velocity, low resistance arterial flow, and high velocity venous flow with arterial component treatment, and confirm with angiography and embolic therapy. So what they do for this is what it looks like. Ooh, going too fast here. So you can see this is highly, highly vascular. So they would go in there and embolize these veins and arteries. Embolization, does everybody know what that is? It's basically where they inject particles, some sort of small particles to basically cut off flow to those veins and arteries, and then it ends up dying off. They can do the same thing for really large fibroids. They can embolize them, and then they will die without any sort of blood supply. All righty, endometrial hyperplasia, this is the most common cause of abnormal bleeding. It is caused from unopposed estrogen stimulation. You will have a thickened endometrium up to 14 millimeters in the premenopausal female and up to 8 millimeters in the postmenopausal female. So I believe that tamoxifen, given as a hormone replacement therapy, can cause this as well. Given to postmenopausal women to help with their symptoms, because once a woman goes through menopause, those fluctuating estrogen levels stop fluctuating. They just get cut off, and that's it. And it causes some pretty uncomfortable symptoms. So some women will seek hormone replacement therapy, and then they could end up with a thickened endometrium, and that's caused by this endometrial hyperplasia. So you can get estrogen producing tumors. Hyperplasia may be a precursor to cancer, and you would need a biopsy to know for sure, because ultrasound is not going to tell us if it's cancerous or not. Everybody knows that, right? Well, as we know is that the endometrium is abnormally thickened. So endometrial polyps is an overgrowth of endometrial tissue covered by epithelium containing glands, stroma, and blood vessels. 20% of the time, you can have multiple. They can be pedunculated, meaning that they're growing from a stalk. Broad-based, which means there is no stalk. It's just kind of the whole base is connected to the wall, or they could be thin stalked. You can be peri or postmenopausal, and it's more commonly associated with bleeding in these women, peri and postmenopausal women. Menstruating women associated with menometrorrhagia, which is heavy bleeding and infertility. So polyps can cause very heavy bleeding. When a woman comes in and they say they've got heavy bleeding, and you do the ultrasound, you know, my first thought is polyps or adenomyosis, or possibly endometriosis. So it's one of those differentials for that. Sonographic findings could be diffuse or focal endometrial thickening, hypoechoic region within hyperechoic endometrium in the luteal phase. Cystic areas may be seen within the polyp. Doppler may show a feeding artery and a pedicle, and hysterosonogram may best delineate a polyp from a submucosal leiomyoma. And this is some examples with that saline injected. This is a big one here, huge. These some little ones and another one here on a stalk. Carpet of small polyps, round echogenic polyps. Endometriitis, inflammation or an infection of the endometrium, most often associated with PID, postpartum or after instrumentation invasion. Clinically, patient presents with low back or abdominal pain, fever, painful periods, heavy periods, constipation, sterility. Sonographic findings is endometrium prominent, irregular, or both, fluid in the endometrium, pus in the cul-de-sac, which is going to look like cystic area with low-level echoes. They could have enlarged ovaries with indistinct margins, dilatation of the fallopian tube, fluid-filled tubular structure folded onto itself, and that is known as hydrosalpinx. That has a distinct look as well and can be very, very painful for the patient. Going in with a trans vag probe can be really very painful. So see how it almost looks like, I don't know, kind of reminds me of like a sausage or something that's curled up and it's got these little, like these are the folds. Okay. And also if these have echoes, then it's probably progressed to pyosalpinx, which is pus-filled ovarian tubes. Sonographic findings could also include periovarian adhesions. A tubo-ovarian abscess is a complex multiloculated mass with septations, irregular margins, internal echoes, fluid debris level, posterior enhancement. I believe tubo and ovarian abscess is when it's gotten really, really advanced. So look like that. It's going to have echoes and not be completely cystic. Okay, this is sonographically, you could have hyperechoic foci with shadowing due to gas in postpartum patient. So see how you have these little ring down artifacts here. Endematous complex endometrium 10 days post-op with intense pain. So what can happen is they don't dispel all of the products of conception, and then it ends up getting infected. And I believe that they have to have a D&C to clear that out. All righty, synechia, endometrial adhesions, also known as Asherman syndrome, found in post-traumatic or post-surgical histories. Uterine curettage, I believe that's a D&C, which is where they dilate, and that D&C stands for dilate and curettage, I believe, where they dilate the cervix and then go in and scrape out the lining of the uterus. Cause of infertility or pregnancy loss. Sonographic findings could be a bright echoes within the endometrial cavity, better seen in the secretory phase, more easily seen in a gravid uterus. Sonohysterography is best for demonstrating adhesion, bridging band of tissue, thin, undulating membrane, or thick, broad-based adhesions. Adhesions can be divided under hysterography or hysteroscopy. So that's what that looks like. These are bridging bands. Alrighty, now on to malignancies. Endometrial carcinoma is the most common uterine Leiomyosarcomas are rare, so cancerous fibroids are rare, and they are impossible to distinguish on sonogram if if you're seeing a fibroid, you can't tell if it's cancerous or not. Suspicious if there's rapid growth with change in the internal architecture, and if there's growth after menopause. Well, why is that a clue? Because if you remember, fibroids are estrogen dependent. Usually, when a woman goes through menopause and there's no more estrogen, they shrink. If they're growing for some other reason than estrogen. So that's a big clue. Sarcoma, okay, botryoids. I don't know what that is, but it is a very rare condition in children. Grape-like clusters of tumor mass. Lymphoma arising in uterus is even rarer. So endometrial carcinoma is the most common. More endometrial carcinoma, most common gynecological malignancy. It is usually an adenocarcinoma, thickened endometrium, uterine enlargement with lobular contour, mixed echogenicity within the uterus, endometrial fluid collection. There must be a biopsy done for diagnosis. I'm wondering if we can see. Well, you know what? I'm not even going to do that. Let's look and see if there's images. No. Let's see if we can find one. Oops. So this one is thickened and it also has like a focal mass here. If you turn it off, if you turn color on, it's going to be pretty vascular. This is another typical look with these cystic structures within the endometrium. This is hyperplasia, actually. But again, you don't know if it's cancerous or not. But you're going to have a hypervascular endometrium. All right, where were we here? I jumped ahead by accident. So sonographic findings are thick endometrium, greater than 5 millimeters post-menopausal, myometrial invasion, so thickened and irregularity of central endometrial interface, may obstruct endometrial canal, resulting in hydrometria or hematometria. So if your cancer has grown to the point that it's blocking the exit, these things can develop. The Doppler of the uterine artery should be done to evaluate the RI and PI. Low resistance is going to be less than 0.4 for resistive index. High resistance, normal flow should be greater than 0.5. The pulsatility index cutoff is 1. Look for intratumoral neovascularity, color Doppler, endometrium. So if you were to Doppler these vascular vessels, they would be low resistance. So cervical cancer can be caused by a virus. That's why everybody's getting the HPV vaccine now as children, because they found out that they can prevent a lot of these cervical cancers. So squamous cell carcinoma is the most common type of cervical cancer. The precursor is cervical dysplasia. So women go in, they have a pap smear, they have changes to these cells, and that's a precursor. So they may do a procedure to try and remove or freeze those cells. Detection is at pap smear screening. Adenoma malignum, minimal deviation. Adenocarcinoma is rare cervical neoplasm arising from endocervical glands. Sonographic appearance will be multiple cystic areas within a solid cervical mass, retrovesical mass, solid cervical retrovesical mass, obstruction of ureters, invasion of bladder, areas of hyper or hypoechogenicity, and irregular outline. So let's see if we can see. I actually just recently read something too, where a woman came in and went to the doctor's office and had a very vascular cervix. And they did some testing on her, and it did end up being cervical carcinoma. So increased vascularity. Anyway, I was hoping to actually see some images. So see the hypervascularity there and here. And obviously, if you see, you know, an outline of a mass, that's a good indication as well. Irregular outline here. So here we go. Transvaginal long. Transverse and color Doppler shows high vascularity. Cervical stenosis can be caused by radiation therapy, previous cone biopsy, postmenopausal cervical atrophy, chronic infection, laser or cryosurgery, and cervical carcinoma. That would be a narrowing of the cervical canal. And the appearance is an accumulation of uterine secretions because it can't get out. It's kind of closed off. So fluid would be hydrometria, pus, pyometria, blood, hematometria. So here we see a fluid-filled uterus, and it cannot get out. And same thing here, but it's filled with blood instead of milk. Other benign pathologies include Gardner duct cysts, which are in the vagina and perforate hymen, hematocolpos, hematometria, hematocolpometria, with their definitions here. And in the uterus, you could have Nabothean cysts, which are usually in the cervix, cervical polyps, leiomyomas, cervical stenosis, adenomyosis, all those things that we just went through. Simple cyst. Remember our STAR criteria: smooth walls, T for through transmission, also thin, T for thin walls, A for anechoic, no echoes at all, and R is round or sometimes ovoid. But the biggest thing, there being no echoes and having through transmission or acoustic enhancement. Hemorrhagic cysts is an internal hemorrhage. So you have a cyst and the wall starts to bleed and the blood collects inside the cyst. You can have it within follicular cysts, more common in corpus luteum cysts. The patient may present with acute onset pain. Sonographic findings are variable with clot formation. Inside the cyst, you'll have those linear echoes fine linear echoes. Acute, it can be, usually it will be hyperechoic because it's fresh blood, may have a peripheral ring of vascularity. The peripheral ring being the wall that's actually done the bleeding within the corpus luteum. Clotted blood becomes a little bit more complex. Internal echoes with no color within, yet should not be vascular. Once the bleeding stops and it's just clotted, and it may show fluid levels, which is two different densities that you saw. And you should rule out a possible ectopic with a HCG or pregnancy test. And that's what they look like. It's fine lines. All right, on to polycystic ovarian syndrome, also known as PCOS, also known as Stein-Liebenthal syndrome, can cause infertility, oligomenorrhea, which is light periods, hirsutism, and obesity. This is excessive hair in places like the face, where hair would not normally grow on a female. It is an endocrine disorder. It causes chronic anovulation. It is also causes bilaterally enlarged polycystic ovaries, common cause of infertility and miscarriage. There will be multiple small follicles along the periphery of the ovary, known as the string of pearls sign. Diagnosis usually made by hormone levels. Ultrasound can raise the question, because an ovary can have the appearance of a polycystic ovary. So if you have 12 or more follicles measuring 2 to 9 millimeters and ovarian volume greater than 10 cubic centimeters, you could, or a patient could, have polycystic ovaries. So this is what that looks like. Here's a string of pearls. So what happens is, with it being an endocrine disorder, is that the hormones that you need to, I guess the luteinizing hormone, the one that is produced within the pituitary to tell the ovary to start maturing an ovum, it never happens. So these are immature ovums. You don't have one mature and turn into a Graafian follicle, and it never is ready to ovulate. So that's how that happens. Benign condition, by the way. Germ cell tumors derive from primitive germ cells of embryonic gonad. 15 to 20% are ovarian neoplasms. 95% are benign cystic teratomas, which are those dermoid cysts, and associated with elevated alpha fetal protein and HCG levels. Average diameter is 15 centimeters. That is huge. 40% calcify, and 85% mostly solid. Let's see if she has pictures. Yep. So they can, because they're made of germ cells, and there's all 3 layers of the germ cell, you can have different types of tissue. I'm sure you guys all have heard this. You can have hair, you can have teeth, you can have fat. I think these are so darn interesting. Let's see if we can get a picture. So, they can grow with this fetal or neonate fetal. You can see them in the sacral area. But here's one that's really interesting. You can see it has hair. So because of this, different densities of the tissues that make it up, you can have varying appearance. on ultrasound. So you can have this calcified appearance. Sometimes it'll be a little cystic, but they refer to this as the tip of the iceberg, where you have this, looks like this calcified periphery with then shadowing. So it looks like an iceberg, looks like the tip of an iceberg. And this here has hair, fluid, and fat, this one here. I guess this is part of it. I'm sorry, I'm not 100% sure what they're showing us here, but at any rate. So dermoid cyst is the most common type of germ cell tumor. 20% are ovarian neoplasms, 15% are bilateral. 80% of the time, they come from childbearing age women. 3 germ cell layers, ectoderm, mesoderm, endoderm, which, as we said, could contain any of those tissues that these will eventually become. 10% are diagnosed during pregnancy. And the size ranges from small up to 40 centimeters. Unilateral, round to oval mass. The appearance can be cystic, complex, solid, echogenic components, acoustic shadowing. It could have that tip of the iceberg look, ill-defined acoustic shadowing that obscures the posterior wall. So here, and you got that shadowing, all kinds of crazy looks. Echogenic mass within the normal ovary, mass with hair/fluid levels or fat/fluid levels. It can also look like what's called dermoid mesh, and that comes from the hair. Multiple linear hyperechogenic interfaces floating within a cystic mass. So let's see what that looks like. It could also have these blobs. Right. This almost looks like this. It almost has the appearance of a hemorrhagic cyst. This is a really good tip of the iceberg one here. Anyway. All right. Okay, here's that dermoid mesh with multiple linear hyperechogenic interfaces floating within a cystic mass. Then you can have para-ovarian cysts, which arise from the broad ligament. Everybody remember the broad ligament? It is a broad ligament that attaches or kind of overlays all of those adnexal structures. Broad ligament of the uterus. So looks like this yellow part right here. So it arises from the broad ligament, demonstrate normal ovary close to but separate from the cyst. The cyst may hemorrhage, may torse, or rupture. The size does not change with hormonal cycles, and they are more common in women ages 30 to 50. So here you go. Separate ovary in between the ovary and the uterus. Peritoneal inclusion cysts are benign cystic mesotheliomas formed with adhesions, trap peritoneal fluid around the ovaries, lined with mesothelial cells, large multiloculated cystic adnexal masses. The ovaries are within or on the margin of the cyst, and recurrence after surgical resection is up to 50%. So here you go. Adhesion attaches to the normal ovary. Okay. Fecal lutein cysts are largest functional cysts. What's a functional cyst? Anybody know? I believe. Yeah. So a functional cyst. So it's producing hormones, and instead of involuting like they should, after your period, they just keep growing. So it is the largest functional cyst, bilateral, multiloculated cystic mass, high levels of beta HCG, gestational trophoblastic disease, 30% of the time. So does everybody remember that the trophoblast, which is the cells in the cells in a, oh my gosh, I'm sorry, guys, my brain is a little, I need more coffee. In a cell that has been fertilized, you have trophoblastic cells, which then are what become the placenta and begin to produce HCG. When those cells go out of control, you can end up with these really high levels of HCG, not because there's a baby, but because there's these out of control trophoblastic cells. So gestational trophoblastic disease is 30% of the time, which is also known as a hydatidiform mole. Those are those partial moles and complete moles. There's molar pregnancies that looks like grapes. Remember that? There's no actual baby. It just ends up being like this. It looks like grapes. That chorioadenoma destruens or choriocarcinoma. So these moles can turn cancerous. Multiple gestations. So I guess they're saying that these cysts can come because of multiple gestations. They can come because of ovarian hyperstimulation syndrome, a complication of which this ovarian hyperstimulation syndrome is a complication of fertility drug treatment. Have you ever seen that in the clinic? I have, and it is interesting. Like really, really large follicles like that and large ovaries. So they involute when the source of gonadotropin is removed. So apparently whatever the hormone is that, so remember with we went over with when an egg ovulates and it becomes the corpus luteum and it produces progesterone unless there's no fertilization, and then it stops producing progesterone and then you end up getting your period. So I guess this is kind of like the same thing, but it's like as if it just keeps producing and producing and producing progesterone, and it keeps growing, and so you somehow have to stop that source of gonadotropin. And I don't know how that happens, whether they give medication for it, but they may rupture, hemorrhage, or torse, and surgical intervention for rupture or torsion. Otherwise, they probably just try and balance it so that it stops growing. So that's that. Pelvic inflammatory disease. Pelvic infection can be acute or chronic. The highest occurrence is among teenagers. Imagine that. Risk factors include early sexual contact, multiple partners, a history of STD, previous history of PID, IUDs or IUCD is the same thing. Douching, which pushes bacteria retrograde up into the uterus and then into the fallopian tubes. Routes of infection, STDs are the most common source of PID. Spreads via the mucosa through the cervix into the endometrium, out of the fallopian tubes to the ovaries and peritoneum. You could end up with appendiceal abscess, diverticular abscess, post-surgical abscess, invasive instrumentation procedures such as laparoscopy, D&E, which is dilation and evacuation, which I believe is the new term for D&C. They now say D&E, post-abortion complications, IUCD, or postpartum complications are all make for routes of infection. Starts out as a bacterial infection, chlamydia trichomatis, gonorrhea. Then you have aerobic bacterias. I suppose these are anaerobic, but aerobes, strep, E. coli, and this influenza. Okay, anaerobics are bacteria, whatever this is. So you have aerobic and anaerobic bacterias that can all cause these infections. I don't think you're going to need to memorize these. Just know that these bacterial infections, which are sexually transmitted, can cause PID, herpes virus 1, this Fitzhugh-Curtis syndrome, which is perihepatic inflammation. I don't know the disease process for that, but I guess that is one of the causes. And chlamydia, gonorrhea are the most common cause. The nice thing is because they're bacterial, they can be treated with antibiotics. So the presentation, the clinical presentation, which is the patient comes in complaining of acute pelvic pain, purulent vaginal discharge. Everybody knows purulent means pus, right? Fever, right upper quadrant pain, painful coitus or intercourse, irregular menstrual bleeding, elevated white blood count, as with any bacterial infection or viral infection, infertility, pelvic mass on palpitation, sonographic presentation can look like endometriitis with a thickened or fluid in the endometrium, para-ovarian inflammation with enlarged ovaries, multiple cysts, indistinct margins, salpingitis, which is a inflammation of the fallopian tubes, nodular thickening, irregularity of tube with diverticula and dilated or tortuous tube. So remember that picture I showed you with the thickened tube, and it had those little non-connecting septa? That's what that's talking about here. Pyosalpinx or hydrosalpinx, fluid-filled irregular fallopian tube with or without echoes. Echoes would indicate pus. Tubo-ovarian complex is the fusion of inflamed dilated tube and ovary. And then worst is, most advanced is tubo-ovarian abscess, which is a complex mass with septations, irregular margins, and internal echoes, usually in the cul-de-sac. So hydro versus pyo. This one has some low-level echoes, a little hard to see, but tortuous. And sometimes you'll see that septa kind of not connecting, but just coming through. rotate on lucency to elongate it. So if you're trying to evaluate, you would want to, you might see, little cystic areas. If you rotate, you'll elongate and you elongate it, and then you'll possibly see that it is the fallopian tube, non-vascular. Okay, hydrosalpinx, acute versus chronic. Acute thickened endosalpingeal folds, creating a cogwheel appearance. So you might have these little protrusions sticking out that makes it look like a cogwheel. Chronic may mimic, minimum thickening of folds. It looks like a string of pearls. Minimal thickening of folds, but you do have this septa. All right. Tubo-ovarian abscess is peri-ovarian adhesions form with increased infection, and it distorts the anatomy. Tubo-ovarian complex, the ovary cannot be separated from the inflamed dilated tube. It is now adhered to the tube. It can be unilateral, bilateral, complex mass, and posterior cul-de-sac. Usually responds well to antibiotic treatment. Sonographic follow-up for resolution or drainage guidance. Peritonitis is an inflammation of the peritoneum by infection, and you would look for collections in the pelvis and abdomen, collections of fluid and or pockets of pus. So here we go with this tubo-ovarian complex. Ovary, tube, looks like one big mess. And then you have the abscess, which now has a complete breakdown of the architecture. So it looks a little different from that, where you can at least still see roughly what's what. Now it's all adhered together. And the ovary and tube are not discernible. All right, on to epithelial tumors. Serous tumors are the most common epithelial tumor, 30% of all ovarian neoplasms. Mucinous, 20 to 25% of ovarian neoplasms. Adenomas are benign. Adenocarcinomas are malignant. So, and of course, they're not going to be able to tell this. You won't be able to tell this from ultrasound, but biopsy would be needed. Benign appearance is thin-walled, no septations. The ovary is going to be thin-walled with no septations. It will have acoustic enhancement, and that can be aspirated. Metastatic spreads from the intraperitoneum. Also direct extension to surround structures and lymphatics. Hematogenous spread occurs late, I guess, through the blood. It gets into the lymphatics, and those cancer cells spread throughout the body, can be very large, fill the pelvis and extend into the abdomen. Serous tumors are going to be smaller than mucinous tumors. So serous tumors are the most common, but mucinous are cancerous. Mucinous cystadenoma and mucinous, oh, I think I lied, and mucinous adenocarcinoma. I'm sorry about that. I thought this was saying that mucinous was going to be cancerous, and this was not, but no. Sorry, guys. Serous is benign, mucinous is cancerous. So within mucinous, you can have benign cystadenomas and cancerous cysadenocarcinomas. So epithelial tumors lined by mucinous elements of the cervix and bowel. If it's a mucinous cystadenoma, that is benign, simple or septate, thin-walled multiloculated cysts. If it's malignant, it will be thick, irregular walls and septations with papillary projections, also known as mural nodules, and echogenic material. If it ruptures, you could have mucoid hypoechoic fluid with bright punctate echoes, and this that pseudo myxoma peritoni. So here we go. This is a cystadenoma, non-cancerous, multiloculated cystic spaces, low-level echoes, again benign. Now this one's cancerous because the septations are now thickened. And you have septal nodularity and a larger size. This one is a large mass with thick septations. That's in here. So serous cystadenoma is a benign epithelial tumor, smaller than mucinous cysts, multiloculated with septations, may have nodule, usually unilateral. Cystadenocarcinoma, loss of capsular definition and tumor fixation, calcifications, peritoneal implants from metastasis, ascites, mets to the omentum, lymph nodes, lungs, liver, or liver and lungs. Cystic structure with septations and/or papillary projections, internal and external papillomas usually present. Again, here is a serous cystadenoma. Okay, mucinous, and then we moved on to serous. So serous can be malignant. Benign cystadenoma. I guess they're not going to show us the cystadenocarcinoma, the serous cystadenocarcinoma. All right, other epithelial tissues, endometrioid, nearly all malignant, 25 to 30% bilateral, postmenopausal, 50 to 60-year-olds. I guess that's the most at-risk group. Clear cell, Mullerian duct origin, 20% of the time are bilateral. Brenner transitional cell tumor is uncommon, benign, more common in 40 to 70-year-olds, cystic neoplasm, other ovary, hypoechoic, solid outer wall calcifications, similar to ovarian fibroma and picomas. It's an undifferentiated carcinoma. Nonspecific, complex, predominantly cystic mass. Tumor may contain hemorrhage or necrosis. And this is a Brenner's tumor. So it is a growth on the wall of an otherwise anechoic cyst. You can tell it has calcifications because of the shadowing. Stromal tumors, sex cord stromal tumors, solid adnexal masses, solid tumors appearing hypoechoic, cystic, but lack of through transmission. Pecoma is an abundance of fecal cells. They are benign, unilateral, signs of estrogen production. 70% are in postmenopausal women. Fibroma is an abundance of fibrous tissue. Meigs syndrome with ascites and pleural effusion, rarely associated with estrogen production, postmenopausal and unilateral. Stromal tumors include granulosa, feminizing tumor, Cells resemble Graafian follicle. They are rare, only 1 to 3% of the time. Are they this kind of tumor, estrogen producing? Sertoli-Leydig cell tumors, tumor androblastoma. They are rare, 0.5%, unilateral, 10 to 20% malignant. And then there's arenablastoma, which is a masculizing tumor, may present with menorrhea and infertility, and 22% malignant transformation. All right, ovarian carcinoma. Different ovarian cell populations undergo malignant transformation. So 65 to 75% of the time, they are epithelial. 15 to 30% of the time, they are germ cell in origin, this is. Stromal or sex cord neoplasms 5% of the time, and 5% of the time, it is from metastasis. Masses less than 5 centimeters are likely to be benign. Masses greater than 10 centimeters are likely to be malignant. And I suppose that in between number is they all need more follow-up, but I guess that's a gray area when it's between 5 and 10 centimeters. Increased age equals an increased incidence of malignancy. History of breast and colon cancer gives you a greater risk of ovarian cancer, and the strongest risk factor is a family history of ovarian and breast cancer. Cancer staging. Stage 1 is limited to the ovary, limited to 1 ovary, stage 1A is limited to 1 ovary. Stage 1B is limited to 2 ovaries. Stage 1C is positive peritoneal lavage. Okay. So did we learn about peritoneal lavage? That's when they inject a solution into the abdomen or the peritoneum and then draw it, and they want to see if there's blood in there. Anyway, with ascites. Stage 2 is limited to the pelvis. Stage 2A has involvement of the uterine, other pelvic structures, uterus and fallopian tubes. B is an extension into other pelvic tissues, and C is positive peritoneal lavage with ascites. Stage 3 is limited to the abdomen, intra-abdominal extension outside the pelvis, retroperitoneal nodes, extension into the small bowel or the omentum. And stage 4 is hematogenous disease, meaning that it's gone through the bloodstream and into the liver parenchyma, and it spreads beyond the abdomen. One thing I do want to say about ovarian cancer, just for yourself and maybe your patients, is they say that ovarian cancer whispers. I'm sure you've heard this before. Very subtle signs and symptoms. I have a family member, distant family member, that just kind of felt like something wasn't right. She went to the doctor blew her off. She insisted that she get more tested, and she ended up that she had stage 3 ovarian cancer. So she was able to get treatment. She's in remission. She had to have a radical hysterectomy. Everything had to be removed. But she's good now. So don't ever let the doctor tell you that they're not going to do testing if you really feel that there's something wrong. So she always says she's so glad she pushed for herself and advocated for herself. There's a blood test they can do called CA-125 testing. It is a serum marker. It is elevated in more than 80% of patients with an epithelial ovarian tumor, cancer tumor. There are high false positives due to non-malignant GYN diseases, such as endometriosis, PID, fibroids, pregnancies, and other types of cancer. Insensitive to mucinous and germ cell tumors. So this CA 125 is not going to help you out if you have these other types of tumors. So sonographic findings of ovarian cancer are adnexal mass. Obviously, we cannot distinguish between benign and malignant tumors. They are well-defined, smooth-bordered, anechoic lesions. If you have well-defined, smooth-bordered, anechoic lesions, that's benign. Irregular walls, thick internal septations, bural nodules, solid echogenic elements, that is malignant. Ascites, extension to adjacent organs, peritoneal implants, lymphadenopathy, and hepatic mets all support malignant disease. So here you go. This is the ovary. You can see this ovarian tissue with this large mass. I wish they had given us a size here. I'd like to know how large that is, but large solid mass in the left adnexa. Metastatic disease to the ovaries. That means it started somewhere else and spread to the ovaries. 5 to 10% ovarian neoplasms are metastatic in origin, can come from the breast, upper GI tract, other pelvic organs by direct extension or lymphatic spread. Krukenberg tumors is mets from the bowel, stomach, biliary tract, gallbladder, pancreas, usually solid. Cystic metastatic disease, rectosigmoid colon cancer. I guess it comes from a rectosigmoid colon cancer. Malignancies to ovaries, often widespread with mets to peritoneum and mesentery with ascites. Common site for metastasis from the bowel, breast, endometrium, melanoma, and lymphoma. Appear bilateral, solid mass with ascites. Oh, it won't come down anymore. Oh, here we go. So here you go, complex solid ovarian mass, 6 months post-diagnosis of adenocarcinoma of the colon. That's a kick in the pants, isn't it? So make sure you get your screenings, everybody. Carcinoma of the, oh boy, this is the last one. Carcinoma of the fallopian tube would be an adenocarcinoma. Clinical presentation would be postmenopausal patient, presents with pain, vaginal bleeding, big sign right there, pelvic mass. Sonographic finding is a sausage-shaped complex mass. Remember I said how that fallopian tube just looked like sausage? Cyst again, solid with papillary projections, similar to ovarian cancer. And here are the references. And that is it. Questions? Anyone? All right. Thanks for hanging with me. Of course.
Thank you.
Of course.